We're going to start with the voting now, and we will begin with a test question. So unless anybody has any questions about the Turning Point software, I'll give you a minute just to open up that app. Yes, it will say polling closed right now, and then once I start the question, polling will open. All right, for our test question, what does Providence, the Providence metropolitan area, have more of per capita than any other U.S. city? Is it Chinese restaurants, donut shops, pharmacies, or art supply shops? All right, we have 6 responses, waiting on a few more.
Maybe that would be around the east side. East side would be art supply, but not for the rest of Providence.
I'd like to take this moment to remind everybody that we have water and coffee, as well as tea in the corner. If you'd like to get up and grab some, this is a great time. Oh, no worries at all.
In my experience, the assistant professors never have a problem with this. It's usually the full professors or the distinguished emeritus professors.
The answer is actually donut shops. The more you know. Tricky, tricky. All right. Steve Pearson, you're up.
Someone spent a lot of time figuring out how to get this meeting on World Diabetes Day and to have the test question, the answer to which is donut shops. Providence moves by Duncan or whatever. Okay. So now we're going to move to further deliberation and votes on questions related to the comparative clinical effectiveness and value of semaglutide. Oops, I hope I didn't just mess that up. So let's see if I can, oh, how do I try that instead? Whoops. Now, I'm probably going to, I am not an assistant professor. There we go. That's been proved. Can I go back? Is that the second question? Yeah, it's the first question. Okay, phew. Okay. So for all of these questions, the patient population of record is adults with type 2 diabetes mellitus with inadequate glycemic control despite current treatment with anti-hyperglycemic agents. That matches in many ways the eligibility criteria for the studies and the, we believe, to a certain extent, the labeled indications. So the first question, is the evidence adequate? And I apologize because I realize now you don't have these questions. You probably do as part of the slides. So if you want to follow, you don't have to crane your necks around. Oh, yes. After we take the votes, you'll be able to turn around and see them. So the first question again, is the evidence adequate to demonstrate that adding oral semaglutide to ongoing background therapy provides a positive net health benefit? David, could you please quickly summarize the evidence and the preliminary ICER evidence rating?
Sure. So if you look at page 5, you've got figure 2 there on A1C in the evidence summary. And the third from the left, the middle one, is versus liraglutide. And you can see that at 26 weeks, the A1C reduction is similar. At 52 weeks, the A1C reduction looks better. The primary outcome was 26 weeks. If you look at weight loss, you can see that it really does look like the semaglutide patients lost more weight than the liraglutide patients.
Oops, there, I just want to head you off. This is versus, this is just adding it to ongoing therapy. So we're not doing comparative. This is adding it to ongoing
I'm on the
therapy.
wrong one.
That's correct.
Sorry about that. Versus ongoing background therapy, you've got the placebo arm there. And so that's the first one there. And you can see dramatically lower A1Cs. You can see substantial weight loss at 26 weeks. We don't have 52-week weight loss. You have the cardiovascular outcome results showing better. I'm trying to give you your best place to look at this. If you look at the league tables, for instance, on page 8, you can see the placebo arm as a surrogate for ongoing background therapy. And you can see for 3-point MACE, hazard ratio of 0.76, remembering that that's combining oral and injectable. Hospitalization for heart failure, no effect, 1.03. Nephropathy, 0.64, that's purely coming from the injectable. And that's really what we have. And so versus ongoing background therapy, we gave this an A rating and said that it was superior.
Okay. Any questions from the council? All right. I just had one quick question about just, this will come up in other ways too, but the generalizability, we haven't talked much about how the patients enrolled in the trials that are the basis for the data. We've been talking about how well they do or do not reflect the general U.S. population of type 2 diabetes for whom these medications will be considered. Any comment on that?
So I think that for the head-to-head trial versus placebo on A1C and weight, you're more similar to the general population. In the cardiovascular outcomes trials, you're talking about high-risk patients for secondary prevention. And so if you believe, and again, this gets at the, is it fair to extrapolate from what happened, for instance, with statins in primary and secondary prevention, where the relative effects are very similar? If you believe that applies to diabetes treatments or to GLPs, then it's okay. If you don't believe that, then maybe you wouldn't see the same degree of cardiovascular reductions in a general population because who weren't on a relative basis if they weren't at high risk.
Okay, great.
And you certainly wouldn't see as big an absolute reduction because
Right.
they don't have the same baseline absolute risk.
Okay. Any comments from the clinical experts on this particular? We'll have tougher voting questions probably to come about head-to-head.
No, I mean, if we're talking about MACE outcomes, I think we're talking about higher risk in the trial, but we're talking about people at high risk for cardiovascular disease. The general population are all at high risk for cardiovascular disease, I would say. So.
Okay. All right, please go ahead and vote. We have 12 voting members. If I did my counting correctly. There we go. And the results are 12 yes, 0 no. Okay, let's move forward. Second question Is the evidence adequate to demonstrate that the net health benefit of adding oral semaglutide is superior to that provided by adding sitagliptin, again, in this population of patients for whom current treatment is not successful? David?
Yeah, let's see if I can get the correct comparator this time. So versus sitagliptin on figure 2, it's the last panel there on A1C. We're looking, again, we're focusing on the 14 milligrams semaglutide because that's where we know the cardiovascular outcomes. You can see that it reduces A1C more at 26 weeks. It reduces A1C more at 52 weeks. It reduces weight more at 26 weeks and weight more at 52 weeks on the next figure there. And then if you go to the league tables, you can see that the MACE reduction is 0.77, and that was statistically significant. You can see the hospitalization for heart failure reduction was the same, that neither one reduced heart failure. And that nephropathy reduction, you don't have a number on that because sitagliptin, nobody thinks it reduces nephropathy, so you could look at the placebo result of 0.64 versus placebo for semaglutide. And we gave this a rating of B+ versus sitagliptin.
Okay, that was pretty quick, but we went through it this morning as well. But let's now let you guys again ask any questions you want about this issue, and I'll reflect with the clinical experts as well in a sec. Jason?
Just a quick break.
Can you pull that a little closer?
Sorry. Just a quick clarification. This is for people with A1Cs above 7. Is that the comparison that's being requested?
It's for people who you think need better control of their A1C is the way we were imagining this question. If you looked at the clinical trials, you'd find that who was enrolled varied from trial to trial.
Okay, so it's just in the assessment of the clinician that they need improved glycemic control.
Yeah.
Correct.
Okay.
Any other questions about the data? If they're still thinking about it, let me invite the clinical experts. Do you have any comment? You don't know our rating system perhaps as well as we do certainly, but a B+ means that we have high certainty that it's better than comparable, that there is an added net benefit. We're not sure how much. It could be very small, it could be large, but it's somewhere better than comparable.
I have a comment. It's not related specifically to Januvia, but related to the question. In the beginning of this document, you mentioned those three drugs are the ones that were compared in the Pioneer trial compared to oral. Mm-hmm. But you kind of said that they represent one from each class. So I do want to point out while we're talking about Januvia here that we do have some differences with the DPP-4 inhibitor. So when you mentioned about nephropathy, we think that linagliptin might have a better effect on nephropathy. When you talked about heart failure, we think that saxagliptin might be harmful for heart failure. So we don't. So I think when we talk about specific, maybe we should just hear, not like we said in the beginning of the document. That's all.
Very important point. And so I think it's well worth noting when the votes are tabulated and recorded in the final report, that this is not intended to reflect a class judgment. This is based on the data versus this one particular drug. So that is important. Lisa?
I have no issue with the conclusion. Of the benefit.
Okay.
Yeah.
Susan, anything you'd like to add? Okay. Any other, again, now you've had a chance to think if you have further questions. Okay. If not, please vote. Is the evidence adequate to demonstrate the net health benefit of adding oral semaglutide is superior to that provided by adding sitagliptin? Oh, that I do not know how to do. Does it time out? It does say polling closed. Oh, I'm not going to go there. It could be some 400. No, I'm not going to say it. Give it a shot now. Semaglutide superior to sitagliptin. There we go. 12 yes and 0 no. All right. Next question. Is the evidence adequate to demonstrate that the net health benefit of adding oral semaglutide is superior to that provided by adding liraglutide? David, now we're ready.
Yes, thank you. Well, I've gone through this all before. If you go to figure 2, and you look at that center column, the 26-week number was the primary outcome, and you can see it looks very similar on A1C reduction, although at 52 weeks, semaglutide looks potentially better. Weight reduction looks better with semaglutide at both 26 and 52 weeks. And then when you get over to MACE, and again, if we go to the league tables, you've got a non-statistically significant 0.87 there for 3-point MACE. For hospitalization for heart failure, a non-significant 18% increase. And then for nephropathy, a non-statistically significant 0.82. So you've got better clarity on the surrogate outcomes, less on these. You can see that there's even some directional question there. We thought that overall it was more likely that this was beneficial, but given the possibility of harm, we rated this promising but inconclusive.
Any questions from the CEPAC? Of David or the clinical experts?
Sorry,
Mm-hmm.
the hazard ratios that you're referencing are from the NMA. Correct.
Yes.
Okay, so
There's indirectness and everything
I hate
else.
To,
Yep.
influence too much, but then there's additional uncertainty about the comparisons in addition to the wide confidence intervals.
Yes, I mean, there are multiple uncertainties in the NMA. There's the uncertainties that are caught up in that the NMA deals with through credible intervals, which have to do with the underlying variance of the studies, and then there's the do you trust that it's okay to be comparing different things in different trials, and there's also the fact that we combined injectable and oral semaglutide and so all of those are there.
Question, Steve.
Brian.
When you talk about net health benefit, are we taking into account some of the other issues such as injectable versus non-injectable, some of the quality of life issues, not just the medical tables?
Good question. To a certain extent, we have a potential other benefits question to make sure that we do capture that, if it's subtle or important. This is a judgment call we don't have a strict rule about whether that kind of impact on quality of life should or shouldn't be considered a health benefit. Most people will view that as something that they would vote on in the other benefit and not on health gain. But it's a tricky call, and I think it's a very reasonable thing to raise. And if in your judgment it has an important enough impact on quality of life to be a substantive component of your vote, I think it's valuable to say so, and it's allowed. Do other people understand? I'm sure you understood the point, the question he was raising. Yes, lift your
I
ears.
would like also to ask our experts about how to interpret the study data and how they will translate to real life. It's a big pill that needs a very specific dosing in the morning, diet, etc. Do you think that the adherence, how much do you think that the adherence in real life will be similar to what it was shown in studies? I'm very nervous about adherence and people being able to take this big pill as they are going to be instructed to do.
I brought up the big pill issue, but I'll say I don't know of any data on sort of big pill resistance. I don't know how many patients actually that's a barrier. I think that clinically we all see that, even with metformin, sometimes it's a large pill, but I certainly couldn't quantitate it myself. I think with respect to taking it first thing in the morning, I mean, we're endocrinologists, so we tell everyone on thyroid medicine to do that, and it doesn't happen a lot of the time, and it's not the end of the world. So what's the difference in efficacy if they don't do it that way? That's a question that I actually don't know the answer to. So if they're not taking it in the real world way, are these benefits going to be mitigated because there's poorer absorption? Will they have more nausea and vomiting and stop the drug sooner? I don't know. So I think those are all really good questions, but I don't have any, certainly no quantitative answers, and can't even really guess at the actual impact.
Whether you're, just one second, whether this comes up as an issue for you on this voting question or when we're coming to the potential other benefits and contextual issues, we've been talking about a big pill, and I just think it might be helpful for us to know, are we talking a snowball-sized pill, a large gumball? I just want to make sure we're all thinking in the same calibrated sense. What's big?
Yeah, so I found that a little hard to find, actually. So I'd heard about this, and then I looked it up, and I don't know, like this big?
Manufacturer,
I mean,
we usually don't,
manufacturer
we
one.
don't usually invite comment from the,
7.5 by 7.5 millimeters smaller than the typical metformin pill. So just to clarify, it's not a large.
But metformin's large, so, and as I said, some patients can't take metformin, so it's how much smaller than metformin?
somebody crumple up a piece of paper and show us.
Yeah, so
it's about
it's 1 point, yeah. So
it's about a half an inch by,
1.5 centimeters.
no, it's more than half an inch.
It's not aspirin. I wonder how many aspirins there are. I could figure out how big aspirin is and do a little volume calculation.
Okay, I just wanted to put that on the table. Sorry, Joanna.
My comment was, it's my understanding, I don't know if somebody can correct me here, but my understanding, if you don't take it as instructed, it's not efficacious. So it's not decreased efficacy. If you don't, I mean, it's already need to be absorbed very well. So if you take it with more water, with a lot of food, it won't work.
As well, but you don't know how much as well. Right, that's
I
the
don't
thing. I don't think it's something I can quantitate.
Do we know? Sorry, can we?
So just so other people who are watching online, please invite you to come up and grab a mic. Just, yeah, go ahead.
So yeah, if it's taken with more than half a cup of water or with food or within 30 minutes, there's no increase in side effects or adverse events, but it does affect efficacy. One thing I want to caution is semaglutide is very long acting, so 7 to 8 day half-life. So if you have an indiscretion one day of the week, we would not expect that to really affect overall control in the long term. If every day somebody eats with it, certainly it would affect that. But occasional indiscretion with not following the guidance would not affect long-term levels of in steady state of the drug.
Okay, so they could take it 6 days a week and save money?
That comment was an indiscretion.
Well, but I'm serious.
We'll come back to that on the policy roundtable. Okay, other questions? Net health benefit. I'm sorry, Joanna, please.
I do want to finish answering.
Please.
I mean, he was asking about the size of the pill, and I think about adherence because of how it has to be taken. I mean, patients get instructed to do a lot of pills in a different way. Statin sometimes at night, and other thyroid pills should be taken on an empty stomach. I think I read last night, on a social group of endocrinologists who are like, oh, oral sema is coming up. Are we prescribing it to everybody or people who are taking all those pills? And I think there's a fear not only from patients, from the provider, how are they going to handle all those pills? In my opinion, if they are well educated, like if they get the right message how to do it, to explain to the patient, it shouldn't be a problem. It's all about education on how you take it. But if you have those patients who wake up and they have certain habits, they have to drive at a certain time, eat at a certain time, be at a certain, at work at a certain time, have their coffee or things like that, I think those are the people who I think you want to be concerned it might not be the best fit. Similar to any drug, when you're deciding if injectable is better than oral, if once a week is better than once a day, this is a discussion you will have with the patient. So in my opinion, you decide what is the next set of action. Is it with this class of medication? And then you decide which form, and is 1 day per week or once per day.
Susan.
Additional comment is when we are changing medications, when they may need to be taken for efficacy, et cetera, we have to look that not everybody's schedule is the same. Not everybody sleeps 8 hours a night and gets up and has a 9-to-5 job. People have shift work, other types of avenues, young children, elderly parents. So in suggesting any kind of change in medication, we do have to look at the individual and when they could take it, because if it's something that is not going to fit into their lifestyle and schedule, it's a no-brainer not to suggest a change.
Good, thank you very much. So with that further context and perspective, questions about the clinical evidence, I see we're probably ready to vote. There we go. Okay, 11 no and 1 yes. All right. Just sometimes, I know this is the first non-unanimous, it's pretty close to it, but would anybody like to just state briefly why they voted no on this one, the evidentiary or other reasons? 11 of you did. Anybody want to volunteer?
I voted no. I voted no in mostly because, again, as David pointed out, there's really a lot of overlap and maybe even some negative, perhaps, evidence. I mean, obviously, this is all very mushy, and I think Jason pointed out this is based a lot on some suppositions. So I did weigh in that I do think probably an oral pill once a day is better than an injection once a day, especially for someone who's needle phobic, but I didn't think there was enough evidence, especially with some of the GI side effects and whatnot, that may or may not be the same for both of them, to say there's any real benefit of one over the other.
Okay. All right, let's move forward to the last comparative clinical effectiveness question. Is the evidence adequate to distinguish the net health benefit of adding oral semaglutide from that provided by adding empagliflozin? So is the evidence adequate to distinguish between the net health benefit of semaglutide and empagliflozin? David?
So again, if we look at figure 2 on A1C reduction, you can see the larger A1C reduction in that fourth panel there at 26 and 52 weeks. You can see in terms of weight reduction at 26 and 52 weeks that those are very similar. In terms of the cardiovascular outcomes on MACE, you've got a point estimate in favor of semaglutide, but wide credible intervals. On hospitalization for heart failure, you can see that empagliflozin is clearly better. On nephropathy, they seem to be almost identical with wide credible intervals. And just again to comment, because these drugs are so similar on these things, if we move over to the harms side, we have the frequent GI side effects of semaglutide. We have not so much showing up in the trials, but well experienced the urinary and genital side effects, particularly in women, of the SGLT2 inhibitors, and then the fear of severe infections, which doesn't show up at all in the clinical trials. You don't see in the clinical trials these overwhelming genitourinary infections that can occur. So common, in terms of frequent harms, the GI side effects are much more common with semaglutide than empagliflozin.
And it all summed up to?
Sorry, we gave, not surprisingly, we rated this insufficient, that we didn't have adequate evidence to distinguish them.
Questions? Greg?
Bureaucratic question.
Sure.
Seeing that 4A relates to 4, are only the people who vote yes on 4 going to vote on 4A, or
Yes.
are you going to have 12 votes on both? Okay.
There may not be a 4A, just, again, depending on this vote. All right, so any questions about, again, you're thinking about this question?
I was just say, if I could ask the clinical experts.
Yes, sure.
I realize it's a surrogate marker, but there does seem to be a clear difference in the hemoglobin A1C. So your thoughts on that?
I think before answering, I just think first it's here, we have to answer this question. I understand like which one come first, but clinically I'd like to see not a battle between those two drugs. They are both orals, and I think it would be great to see how they work together as compared to which one comes first. But in terms of A1C, in terms of clinical significance, with all honesty, it's not the main thing that make me as a clinician decide between those two drugs. It will make me decide between a DPP-4 and a GLP-1 or insulin and something, because there's a big difference. When it comes to A1C reduction, is not the only thing that make me decide between those two orals if I have to make a decision. Because we're talking about additional benefits. Those are the things I would look at, and side effects and other benefit when I'm making the decision.
Yeah, I agree. There's multiple things that go into the decision. Focusing just on the A1C lowering, I think it's important to not lose track that that still is important for our patients with diabetes. We haven't talked about retinopathy. That remains the leading cause of blindness in the United States, and none of these drugs have any effect on that. And as a clinician, one of the things I worry about is all this focus on cardiovascular disease, which is very important because that's what our patients die of. We let A1Cs ride up, and we lose track of some of the other complications, including amputations and neuropathy and retinopathy that need A1C lowering as the only effective strategy, at least so far that we know of, to help prevent those complications. So I do find the difference in A1C lowering clinically significant. It has to be taken into account with all the other things we've talked about. And I think EMPA and the DPP-4s are very similar. They're not great at A1C lowering.
Thank you again. Any other questions? Okay, please go ahead and vote. Distinguishing between semaglutide and empagliflozin. Okay, 11 no and 1 yes. So we will not have a vote on 4A. We're going to move through to talk about the potential other benefits and contextual issues now. Okay, so here we intend to talk about and try to capture for decision makers some of the issues that, again, can reflect important elements of value, but which may be difficult to measure or measurable, but just not included in the clinical trial data. So the question reads, for patients currently receiving ongoing background therapy, does adding treatment with oral semaglutide offer one or more of the following potential other benefits or disadvantages? And there are only two, but you can select one or both or neither. The first is this intervention offers reduced complexity compared to liraglutide that will significantly improve patient outcomes. B, there are other important benefits or disadvantages that should have an important role in judgments of the value of this intervention. So that's where we can identify either by consensus or people can have their own ideas. We'll talk about whether you think there are other important benefits or disadvantages, potential benefits or disadvantages that decision makers should keep in mind when making an overall judgment of value. So let me invite the patient representative, if you'd like. Anything jump to your mind when you see these two questions? Obviously, the second one is a Rorschach test. Is there anything you would like to add to the discussion around specific potential other benefits or disadvantages of semaglutide that you think are important?
The benefits and the disadvantages that have been discussed earlier today, I would also mention again, I wouldn't really use the word fear of something in choosing one over the other. And I think it just completely is on the advantages or disadvantages of what may have worked in the past and before you do go on to another one, but nothing that I would add significantly to this question.
Okay. Clinical experts, please feel free.
I'll add here that, these are for patients who are on therapy. Would you add the first A says that it reduces complexity compared to liraglutide. We don't want to forget that the majority of patients with diabetes are taken care of by primary care providers who do not have the capacity to start injection in the office. It's true that starting a pill will take, as Rybelsus will take more time, explain how to take it, but definitely less time than starting somebody on an injection. So if we're talking about primary care providers, I think it does, not to answer the question, but there's this complexity of going on injection is in my mind, is difficult to do it in primary care office. When we're talking about endocrinologists who care about the smaller minority of patients with diabetes, that might not be a difference for them. Starting an injection is a complex. That's why cardiologists until now, who should be prescribing SGLT2 or GLP-1 to our patients, still after all the initiatives that have been taken by ACC, and they haven't been able to start those drugs on their patients yet.
David, anything you'd like to add? I know you've mentioned a little bit before your view from the primary care perspective.
Yeah, I think the injection issue versus oral is a really big deal in this drug space, and that it's going to cause more primary care doctors to be using this class of medications. I think from a patient complexity standpoint, many patients are unwilling to take injections, and also they have to be educated in it. I do think, though, that the dose escalation regimen and the take on an empty stomach is added complexity in some ways compared to injections.
Any perspectives on that? Yeah, Jason, or questions?
I think these points, Dr. Mitri's point was, I think it's a critically important point, and I just want to confirm my understanding. This is a tremendously prevalent condition. My understanding is also there's a problem with supply of endocrinologists, right? I mean, I think if we're concerned about treating a huge number of Americans with something that there's a complexity issue that makes it easier to do in primary care, that to me is extremely persuasive.
Yeah, I will say, at least my experience in sort of California, and I think, endocrinologists take care of a very, very small percentage of patients with diabetes in the United States, and I think every primary care practice has a way of teaching of insulin injections. I hope they don't all have access to diabetes educators, but many do because of the prevalence of it. So I do think there's a barrier to injections for all the reasons people said, but I think most primary care clinics know how to teach people to use insulin. And certainly if you look at large systems like Kaiser or Geisinger or things like that, it's all done by nurses, and primary care physicians don't actually have to do any of it.
I will add that endocrinologists have CDE in their office, and they have nurses. Primary care sometimes have assistant, and they have sometimes drug reps sometimes starting to pay patients on injection. So it's true that primary care have nurses, but the availability of having an educator who can bill for it, because primary care also want to see how they can use their resources in their office to maximize income. So they definitely don't want to use a nurse if she's not able to bill for such a procedure. So there's more than just explaining how it works. It's just getting the patient with an appointment to get the education on this. There's something else.
We'll come back. We'll come back. And from the patient perspective, they may have in their mind, because they may have been told in the past that if you don't start to make some changes, the threat is that you will go on an injectable medication. And then people's minds go to, and the needle's going to be this big, they don't realize that it's not going to be. So in the final judgment of what the medication might need to be, and the best medication for that person, those options often need to be discussed and in a way that it's not really fear-based. That's one piece of it. And the other point that I wanted to make in the discussion and the collaboration with the person with diabetes is to make sure that other pieces of changes in their life are also happening before any medication change does happen. Did it come back?
Well, it was actually not an important idea, but just remind everybody. So these trials comparing injectable or liraglutide, this is a clinical trial. Patient goes in the trial knowing they're going to get one versus the other, and they accept. But in real life, patients don't have to go on injection. So try to convince a patient to go on injection versus oral. In a primary care setting, I think it's much difficult.
One more point. Not to get into the weeds on it, but what your point was really well made, that when somebody does see a CDE in the office who may also be doing something like medical nutrition therapy for reimbursement basis, there are really strong rules of when things can be billed and if they're billed under the endocrinologist. So they may have to come back and forth for appointments, and they're not willing to do that to go on to an injectable medication on top of the other issues around it.
Mm-hmm. One thing I just wanted to make 100% clear, it may already be, but in A, when it says offering reduced complexity compared to liraglutide that will significantly improve patient outcomes, don't think of a patient who's on liraglutide who would be switched to the oral necessarily. This is really, does its reduced complexity improve patient outcomes perhaps by expanding the number of patients who will be adequately treated? So, I mean, it doesn't need to be one patient that you're thinking about going from one to the other. It's kind of a broader issue. Yes?
So A explicitly says compared to liraglutide.
Correct.
B does not. Should we infer that it's compared to
you can consider that covered in A.
I think I wanted to add that we discussed, all this discussion was making comments about A. I think in B, they're trying to say that, does it really matter, when you have a patient in front of you, does it matter, are you going to go all the way, treat him like a cancer patient? I want to go for the best regardless of complexity and everything. It doesn't matter if it's oral or injection, or it's insulin or whatever that is, or it's telling you that you really just so, you want to weigh the advantage of how far you can go regardless of the form.
So just to answer Ed's question, A, we picked the injectable. It didn't make any sense really to talk about reduced complexity compared to the orals. Right. B, we wanted to let you guys say any other that you wanted against any of the comparators.
No, I think A will contain the issues of beneficial, to some patients certainly, reduced complexity. Yes, Claudio.
I would also add that I think in terms of B, one of the considerations could be the impact on family caregivers to the extent that they have to work on doing an injection or worry about harming their loved one. It's a real stress, and it's something that could be a barrier. So I think that's an additional contextual consideration.
I'm up for that one being B. In a sense, I think it makes it clear that there could be broader elements of benefit to the family from having a reduced complexity option. Okay? Do I hear, is that okay? Consensus that will be B?
or 6?
Okay, why don't we go ahead and vote. You guys, again, I won't know if you're done voting until you kind of look up at me, but you can vote for none, for A, and or for B. And when you're done, just look up at me.
Steve, I just...
Oh, I'm sorry. Yeah.
With B, I feel like we're kind of dancing around that this is a difficult oral with the titration and all of this. And I wonder if that actually shouldn't be thought of as a disadvantage, not to liraglutide, but relative to the other orals, because liraglutide is dominated in the economic model anyways. So shouldn't we be asking, is this an other consideration disadvantage
versus the other
relative
orals?
to the other orals?
Let's just have a couple
Can that
secs
be
at
C?
least discussion on it. No, that's C. Yeah, no, that can be C. Well, no, we don't have C. Sorry. We will have to either accept it on consensus or take a hand vote, which we've done sometimes. But I hear what you're saying, and I think that wasn't included in any way in the B that we just talked about. I don't know how big the other orals are or how much more difficult, quote unquote, they are to titrate up. Maybe we can ask the clinical experts just briefly. Is there a distinction there that's worth noting?
I think you already mentioned metformin's about the same size, and also metformin you titrate up for the GI side effects. So I think it's very similar in that respect.
Compared to the other oral, the SGLT2s, I guess, and the DPP4s.
I think they're smaller.
Yeah, they're smaller. The others are smaller.
And DPP4 too small.
And what about the titration on the SGLT2s? Is that a consideration?
You can start with empagliflozin, you can start even with 25. The adverse event rate is not much higher with 25 versus 10. The other one, DPP4, it's a one dose, is based on kidney function.
Okay, so what I think we'll do, we'll have the vote on A and B as we talked about, and then C, we will note in the record as an issue for decision makers to consider unless somebody strongly disagrees.
Or just fill in the blank.
Fill in the blank on B.
No, I know, but we already have a B that we're voting on. That's right. Okay, so who's still voting on A and B? Everybody done? Okay, let's see the answers then. Okay, 9 on A, and, shoot, I need to move this. I can't even see it. It's probably up there. 6 for B. Okay, so noted. Let's move to the contextual considerations, of which we have 5, and the 5th one is another fill in the blank. So these are contextual considerations that are important in considering the value, long-term value for money of, at the current pricing, estimated, of oral semaglutide. So again, this gets at some intangible or sometimes what people consider to be ethical or social values around health gains for different populations. First, this intervention is intended for the care of individuals with a condition of particularly high severity in terms of its impact on the length and or the quality of life. B, this intervention is intended for the care of individuals with a condition that represents a particularly high lifetime burden of illness. C, there's a significant uncertainty about the long-term risk of serious side effects of this intervention. D, is there a significant uncertainty about the magnitude or durability of the long-term benefits of the intervention? And E is something else. Anything else? Any comments that you might have or questions about these contextual issues? If you're already thinking that you think you're going to vote that, yes or no on any of these, if you want to share your thoughts with other CEPAC members to get that out on the table. Yes, Martha.
So this is all very anecdotal, but certainly there's a big range of how type 2 affects people, and I don't have a real sense of whether the preponderance of people with type 2 diabetes really do have, considerable numbers of complications, or whether I've seen many patients and have had many friends and family who've had type 2 diabetes, and they go about their life and it's all, doesn't seem to be particularly short or unpleasant. So I'm just trying to get more of a sense clinically about, if we're going to say something about high severity or something about particularly high lifetime burden, what's your gestalt of that?
Because many people don't know that they have type 2 diabetes for a long period of time before they're diagnosed, people are often diagnosed with a very high hemoglobin A1C level. I've had people in my practice with type 2 diabetes with A1Cs above 11, very, very high, which means that their blood glucose levels have been very elevated for a long period of time, and they do therefore present with complications. So in that light, and that goes across different demographics and different socioeconomic statuses and people who are busy and may not have followed up on it and found out at different times. So it can affect and present with complications. The difference is from, for example, in type 1 diabetes, the onset is much slower in certain circumstances, so it's not an issue until it's an issue with the complications part of it.
Thank you. I think what I'm really getting at, though, is what proportion of patients do present late like that versus people who have long-standing diabetes too, which is under control. I just don't have a sense, if I take a population view of this, what that looks like.
There's a lot of patients with diabetes who don't know they have diabetes. I think it's 1 in 3 that they have diabetes.
Okay, thank you.
That they don't know that they have diabetes, and they are complex.
Rob?
Well, I just want to, I guess, add to or enhance Marta's question by thinking about what's the context for the contextual considerations. I mean, we've just come off of 2 cases of major childhood diseases that have a profound impact on life and quality of life if a child is able to have any life at all. We've also considered things like psoriasis, for example, that can prevent them from working, from marrying and having a family. So that's what I'm thinking about as I consider the context in which we evaluate the severity. And I'm not inclined to say yes.
Yes, Lisa.
Yeah, I mean, I think this isn't going to exactly yet answer your question, which I think we've been going around, but I mean, as I said, it's the leading cause of blindness in the U.S., it's the leading cause of end-stage renal disease requiring dialysis, and it's the leading cause of non-traumatic amputations in the United States. So there is a big impact, and that hasn't changed for many decades. I apologize, I don't know the prevalence off the top of my head of the complications, but I think the other component on quality of life, even among those people who seem to be going on about their day-to-day life, is the psychological burden of a disease that you have to think about every time you eat, every time you do kind of anything, and I think that's huge. And I don't know if Susan wants to speak with her experience with patients around that, but I think that's more of a hidden burden that really is very large for our patients, because unlike your blood pressure where you take a pill in the morning and you forget about it, if you're really thinking about your diabetes, you're thinking about it all the time, and that's hard.
Just before she answers, I want to hear Susan comment too. We are moving in our proposals for the next iteration of the value framework will include some more empirical information around quality shortfalls in both absolute and proportional that may give you some empirical guideposts. Right now, it's a little bit more, as you said, kind of gestalt comparing to broader areas. The reasons that these are usually added as a contextual consideration is at least one way to think of it is that we're always trying to capture the quality gains, right? Length of life and quality of life. Sometimes we may feel that there are certain situations where the quality gain is at such a low end of people with very severe conditions or for whom their lifetime burden is so high that we want to give an extra credit to the quality gains for that condition on that basis alone. So that's one context, if you will, around which this contextual consideration is considered to be more important, just if that helps a little bit. But please, Susan, too.
Thank you, Lisa, for mentioning that. Above all, when we even speak about diabetes and we put it into buckets of medication taking and eating and exercise, above all of it is the emotional and mental burden that goes along with it. And when we talk about quality of life, something that doesn't often get discussed, and men do bring it up, and women, sexual dysfunction, pieces of that in the quality of life is also thought about, and also in the younger, middle age, and older population with type 2 diabetes. So it all goes into the mental health aspects, the emotional burden. This all goes into quality of life. It's not just about A1C outcomes.
Good point. All right, let's go ahead and vote, please, on, I don't think we have an E, so you can just leave that off, unless you didn't get a chance to say your passionate E. You can do it after the vote, but otherwise, A, B, C, and or D. And I'll look around to see when I think people are done. You guys are quick. I'm still, okay, Leslie's still voting, done. Okay, Claudio. Rob, you done? Okay. All right, so out of 12, we have 5, 7. That's the highest one is for lifetime burden of illness. 5 on uncertainty of risks, 5 on uncertainty of benefits. All right, let's move to the, if you will, the cumulative or the summary vote in which the comparative effectiveness, the cost effectiveness, the potential other benefits, and contextual issues come together. And the question is, given the available evidence on all those factors, what is the long-term value for money of treatment with oral semaglutide versus ongoing background therapy alone? And the choices are low long-term value for money at current pricing. Now, I need to make, again, emphasize that we have used an estimated net price in the modeling results that I'll let Greg summarize again in just a second. So that's important, and we will make sure that that gets noted. B, intermediate long-term value for money at current pricing, and C, high long-term value for money at current pricing. And Greg, would you please just reiterate again and show them in the evidence summary where the cost effectiveness results were?
Yeah, I'll take it for Greg since he stood up here and did the fancy charts.
Please do.
So against background therapy alone, I think I would refer you to the probabilistic sensitivity analysis where against...
Can you just tell them which page you want them? It should be in the evidence summary. Oh, it's in the slides, okay.
Yeah.
Table 11 has, I think, some of the results as well in the evidence summary.
Yeah,
it does, actually. It has the PSA results.
PSA results are on there, yeah. So at a willingness to pay of $100,000 per quality, oral semaglutide had a 34% probability of being cost effective. And at a willingness to pay of $150,000 per quality, it had an 83% probability of being cost effective. That was at a estimated net price of $6,103 per year using the discount from WAC that's currently applied to the injectable version of the drug.
Right. And the point estimate was $140,000 per quality, right?
That's correct.
All right. So I know we're now talking about the cost effectiveness while also wrapping in these other features. Any questions or comments about how you're thinking of putting this together? Steve.
Is the cost
Sorry, Steve, can you pull the mic
Sorry.
close?
Is the cost of oral sema included in the tornado analysis?
Tornado, yes. Yep.
Steve, you had wanted to, I think, raise a question about the uncertainty of some of those.
Sure, and I had raised
right.
the question earlier about the, just maybe your thoughts about the uncertainty in the tornado analysis, sort of leaning towards ICERs greater than 150K per quality, whereas the point estimate landed at 110 per quality. You know, it just seems like the uncertainty sort of weighs more towards the higher side than the lower side, just in general in Figure 5.
Pull it up here. Hang on. Oh, there. Yeah.
And I forgot my glasses. That's why I can't see the cost of the drug. But which line is it? Where is it?
Yeah, those are all. So everything that's driving the incremental cost effectiveness ratio is not the price of the drug. It's other events and other input values.
So Ryan, his question is, if you look at the tornado diagram, Figure 5, one could gestalt that a lot of the univariate uncertainty leads towards higher ICERs.
That is fair, but I think that's just one-way uncertainty, varying one parameter at a time. And really, the focus, I would direct you to the probabilistic sensitivity analysis, because that's really giving you an estimate of the overall uncertainty of the model at the different willingness to pay thresholds.
Martha.
So for those of us who felt that there was a lot of uncertainty in general about long-term issues with this, it's challenging to talk about what the long-term value for money is. And I'm wondering, is there a not applicable?
No, at the FDA, when their advisors say there's so much uncertainty about the FDA says, sorry, is it or is it not safe and effective? You get one vote. So to a certain extent, we're kind of recognizing the uncertainty that's there in every single topic we look at. And even after launch, it doesn't all go away. Sometimes it gets higher when you've got real-world evidence showing you different things in the RCTs. So it's certainly important to take into consideration, but the judgment is to guide decision makers around, given the current best state of the evidence and our judgments around its uncertainty, what would we say about at current pricing our best judgment of this value? Some people believe, and I've heard this said at many meetings, the more uncertainty, the lower base case cost effectiveness finding I want to have a reasonable value. That's just my approach to it. Not everybody feels that way, but that's one way to wrap in uncertainty into your thinking.
Steve, could I just correct? I think we said 140, but that was against sitagliptin.
Oh, okay.
It's 110 against background
I was
therapy.
channeling David Rind.
So yeah, for this question.
Okay.
For this question, it'd be 110,000.
Thank you for correcting that before the vote happened. So I'll say it again too. Apologies. The base case is 110,000 per quality, with, as you see, the PSA results and the cost effectiveness acceptability curve, basically. Other questions or comments? Thank you, Martha. Others? And Steve? Okay. Why don't we go ahead and vote then? This question is oral semaglutide versus ongoing background therapy alone at current estimated net pricing. A is low, B is intermediate, C is high. All right, here are the results. Little bell curve. All right, we had 4 low long-term value for money at current pricing, 6 intermediate, and 2 high. Let's have a couple minutes then of teasing this apart. I think we got some of the issues that I think people might have been weighing differently on the table, but could I invite someone who voted high long-term value for money at current pricing to describe how they put these elements together for their vote? There are 2 of you. Jason, were you one of them?
I don't want to preempt my colleague, who I'm not sure who it is.
Go ahead.
I was persuaded by a couple of things. I was admittedly waffling, and I maybe even changed it, between B and C. And so in the PSA, there was sort of a series of different, there's in a PSA you have different outcomes, but the median outcome was 110,000, so that fits well with the commonly accepted WPP threshold. And then I also felt, and I remember that we've talked about this with the methods with ICER, and we've gone in different ways on this, but I'm trying to, without being too verbose, I'm trying to deal with this fact that I do think our society kind of owes diabetics something, and maybe that should affect the WPP threshold. And what I mean by that is that there's a lot of things that are outside of medicine that we do, the way we set up cities, the way the food supply is run, that makes it more likely to get diabetes. And I move my WTP threshold a little bit up. Mm-hmm. I'm not sure if I should be doing that in the other contextual considerations votes, so apologies if so, but I'm trying to just deliberate openly in terms of what I'm thinking, and that influenced my thinking.
Yeah, I mean, I appreciate your saying it, and it's not unusual for us to take these votes and for a contextual issue to have suddenly surfaced in your mind after we've had the votes on contextual issues. So it sounds like there is a contextual issue around this condition that helped influence the way that you looked at the findings and put it into your vote.
Yeah, maybe a crisper way of trying to say what I'm trying to say, trying to articulate what I'm trying to say is that, the way we set up roads and the way that manufacturing works in America grows the economy. So there are economic effects of that. So as such, we have a duty to those who have been hurt by those systems to adjust the WTP threshold. I think that's maybe a little bit better way of trying to get at what I'm getting at.
Interesting.
Spend money on the roads.
I'll skip intermediate for now unless someone feels passionate about being intermediate. To ask if anybody who was in the low long-term value for money to express their views on why that was their vote. Now there are 4 of you. Don't be shy. Martha, were you one of them because of the uncertainty issue, or did you? We have 4 low long-term value for money at current pricing.
Yeah,
if you weren't, that's fine.
No, it's all right.
I thought that might have been one of them.
Chat. I think I'm bothered by the uncertainty. I suspect that I'm full on the side of people here who think that what we consider reasonable thresholds are, pretty expensive. And so that would be my sort of default position.
All right. Fair enough. Anybody else want to add a different perspective on that as we capture it for the record? Lefterios.
I just want to make a point that I was one of the 4, so I'm not shy about saying it. I just didn't want to monopolize it. But I just want to make the point also that additional uncertainty is how the study results, that at some points are borderline, can translate into the practice of a chronic illness where compliance and exact, taking of the medication is so important day after day, and how this is going to translate in real life outside of compliance, when even with insulin, about 1/4 of people are rationing insulin and they cannot take it. So all those things make the study results even more questionable how they're going to be translated into real life.
All right. Well, that's
there was a week ago, there was a case in Minnesota of a person that died because he was rationing insulin. This is real life. This is happening.
That's a great segue to what we'll be talking about in the policy roundtable, about the broader clinical patient research, pricing, and coverage issues related to this whole area.